Welcome back to this series. Today we're going to cover some of the highlights of the injectable anesthetics, including barbiturates, dissociative anesthetics, propofol, etomidate, and alfaxolone. How do you use them, and how do they differ from each other? The history of anesthesia begins with some of the oldest attempts to block pain. For example, laudanum is opium, a crude extract from poppies, dissolved in alcohol, meant to be taken orally. This was used widely, especially during the Civil War. Unfortunately, at high doses, laudanum has the effect of blocking respiration without actually inducing a true anesthesia. Chloral hydrate was used in an attempt to cause anesthesia, but as we've already discussed, chloral hydrate is actually just a sedative, at most a hypnotic. It's not really safe at doses that are high enough to cause a loss of consciousness, and it's not even analgesic like laudanum. When sodium barbital was developed, the first pharmaceutically active barbiturate, it caused barely a blip in the medical radar because it was only a sedative, or at best a hypnotic agent when taken orally. So how did the barbiturates become popular, and how did they lead to the variety of drugs that are used today? What really propelled the area of anesthesiology forward was, surprisingly, not the development of new drugs, as much as two technological developments: when the syringe was developed and when sterilization of the syringe was possible. This allowed drugs to be delivered more rapidly than before, when they were almost exclusively given orally or inhaled like ether. With a syringe, pentobarbital and eventually the thiobarbiturates were given fast enough so that they could be used to induce anesthesia. Even more dramatically, they could induce anesthesia without as much of the initial excitation that was produced when using compounds like ether. The injectable anesthetic drugs that emerged over the years include the barbiturates, the dissociative anesthetics like ketamine, propofol, etomidate, and alfaxolone. The excitatory tissues are all sensitive to many injectable anesthetics. They include the heart, smooth muscle, skeletal muscle, and finally the nervous system. But it's the nervous tissue in the brain with its GABA-A receptors that have the highest sensitivity to these compounds. This is the site of action for their ability to induce sedation, hypnosis, and anesthesia. Their effect on other excitable tissue are responsible for some of the side effects of these drugs that usually include cardiac, vascular, and skeletal muscle effects. So how do injectable anesthetics produce unconsciousness? We've discussed barbiturates before in terms of phenobarbital and its sedative and anticonvulsant actions. They produce these effects by interacting with a binding site on the beta subunit of the GABA-A chloride ionophore. By doing this, they allosterically enhance the time that the channel spends in the open position. This allows more chloride to flow through than would normally happen in response to its activation by GABA. This hyperpolarizes the nerve on which the receptor sits and decreases its tendency to be active. Although newer drugs have been developed since phenobarbital, the GABA-A receptor complex is still the main target of most injectable and all inhalant anesthetics. Except for the dissociative anesthetics, they tend to couple and enhance the chloride ion flux. The unique characteristics of these drugs result in part from their interaction at different sites on this receptor complex. So why don't compounds like phenobarbital induce anesthesia, while other compounds that act at this same site do? Let's take a look at the structures. Barbituric acid is a weak acid, so it's put into solution using sodium hydroxide. It can be either an oxybarbiturate with oxygen, where the X is indicated, or a thiobarbiturate with sulfur in that position. But even when it's in solution, it's not active as a depressant compound. In order for barbituric acid to be pharmacologically active, it needs to have substitutions at any of these three positions where R1, R2, or R3 replace the hydrogen ion. So what is it about these three substitutions that give them their characteristic depressant action? The structure itself of each compound has a certain degree of lipid solubility. As it says here, the more lipid soluble, the more potent, the faster the onset, and the shorter the duration. In addition to the structure, the dose of the drug is ultimately what the clinician can control. Obviously, the higher the dose, the more depressant the effect. The route of administration is also important. For example, even if an ultra-short-acting compound were given at an anesthetic dose, but ended up being administered orally, this wouldn't be nearly as depressive as if it were given IV. The intravenous route allows a huge amount of drug to hit the brain all at once before it distributes to other tissues. It's also important to consider the excitatory state of the animal when an anesthetic drug is administered. If the animal is already depressed, it will take significantly less drug to induce an anesthetic episode. In contrast, if the animal is very excited, it may take more drug to counteract this effect. For this reason, when administering barbiturates, about 2/3 of the calculated dose is given fairly rapidly, and then the remaining third is given as needed to achieve the desired degree of depression, or to effect. Finally, the degree of tolerance and dependence on depressant drugs needs to be considered. If the animal has been treated with phenobarbital for years for an epileptic condition, it's become cross-tolerant and cross-dependent on any other depressant drug used for anesthesia. Tolerance means that a large dose is probably needed to produce the desired depressant effect. Dependence means that withdrawal from the anesthetic may cause seizures more readily. Once there are substitutions on the barbituric acid molecule, they can do any of a number of different things. The simpler compounds, with the shortest and simplest substitutions at those R positions, are long-acting depressant compounds, capable of inducing sedation or even hypnosis, but they're not safe as anesthetics because they induce too much respiratory depression at doses that would be needed to induce anesthesia. In addition, the resulting anesthesia would last far too long to be useful. Depending on the substitutions on the barbituric acid structure, some, but not all, long-acting barbiturates are also anticonvulsant. Phenobarbital is the most widely used compound in this category. With ever more complex and longer side chains attached to the molecule, they become more lipid soluble and shorter acting, and or as some textbooks refer to them, intermediate acting. These drugs are usually used for their hypnotic or anesthetic effects. Pentobarbital would be one in this category. Finally, the most recently developed barbiturates have complex molecular substitutions that make them even larger and more lipid soluble. These drugs are the ones that are used as induction agents. That is, they induce an anesthetic effect very rapidly when injected IV. But their anesthetic effect doesn't last long, so they're usually followed by another longer-lasting compound, like a gas anesthetic. Gases don't generally induce anesthesia rapidly. As a result, they cause a lot of anxiety and struggling on the patient's part. But the anesthetic action of gases can be maintained longer. So it's the marriage between these two, the gases and an induction agent, that produces a balanced anesthesia. Remember, too, that anesthetic doses of short and ultra-short acting barbiturates, as well as some of the other injectable anesthetics, can be used as emergency anticonvulsants. There are hundreds of barbiturates, but only a handful on the market. These are just examples of drugs that fall into the three categories of long, short, and ultra-short acting compounds. Barbitol and barbitone, as they say in Britain, has a simple ethyl substitution at R1 and R2. It was the first barbiturate-based sedative developed. Phenobarbital has a phenyl group instead of the second ethyl, and this gives it not only a slightly greater depressant potency, it also renders it anticonvulsant, the primary use for this compound to this very day. As the length of the substitutions increases, as in pentobarbital and secobarbital, they can be used as anesthetics, especially in laboratory animal medicine, but they're slow to induce anesthesia and may produce a rough recovery. The use that you'll be most familiar with clinically is in euthanasia solutions, that is, pentobarbital mixed with phenytoin. Finally, the shortest acting or ultra-short acting compounds include things like methylhexatol and thiopental. They're induction agents, but their use has also been eclipsed by the more recently developed compounds that induce a smoother induction and recovery. So let's compare the types of substitutions made on some of the more commonly used drugs from each category and the resulting pharmacokinetics, that is, their absorption, distribution, metabolism, and excretion. First, we're already familiar with phenobarbital. Here you can see the partition coefficient, that is the lipid-water solubility ratio, is 3. This means that phenobarbital is 3 times more soluble in lipid than in water. We know it has a slow absorption from the gut, a slow entry into the brain, and a relatively low plasma protein binding. About a third of phenobarbital is excreted in the parent form, whereas as much as 90% of barbital is excreted as barbital itself. The action of phenobarbital is terminated by a combination of redistribution, metabolism, and excretion. Of those, metabolism and excretion play the major role. Now we can compare that to a short-acting barbiturate. In this case, it's pentobarbital. It has a partition coefficient of 39. That means it's about 40 times more soluble in lipids than in water, or 13 times more soluble in lipids than phenobarbital. As a result, it's more rapidly absorbed from the gut. It can pass through the lipid bilayers, so it passes the blood-brain barrier into the CNS more readily. And it has a higher binding to plasma proteins, creating a reservoir of drug in the circulation. And hardly any of it is excreted as is. It's almost completely reabsorbed in the kidney tubules, so the termination of its anesthetic action is based primarily on its metabolism. Finally, we want to see how an ultra-short-acting compound like thiopental compares. Thiopental has a partition coefficient of 580, so it's 580 times more soluble in a lipid than in water. That's about 15 times more lipid soluble than pentobarbital and 200 times more lipid soluble than phenobarbital. It's absorbed from the gut and passes into the brain very rapidly. A higher percentage is bound to the circulating plasma proteins, and nothing is excreted by the kidney in the parent form. So it's eventually metabolized. But in the meantime, the animal wakes up. Why is this? Because the anesthetic action of thiopental is terminated by redistribution of the drug from the brain to the rest of the body, rather than either metabolism or excretion. So you can see that substitutions on the barbituric acid molecule that give the compound a certain degree of lipid solubility also make them fall into either the long, short, or ultra-short acting category. They all undergo redistribution, but that process becomes increasingly more important as the lipid solubility of the drugs increases. The delivery of barbiturates depend in large part on what it's being used for. When used as a sedative, hypnotic, or anticonvulsant, it's usually administered orally. But when it's used as an anesthetic, it has to be given by a route that delivers the drug more rapidly. So the majority of the time, it's injected intravenously. If the needle slips and the drug is inadvertently injected peривascularly into the subcutaneous area, it can cause stinging and even tissue sloughing, depending on the drug. But when an IV injection doesn't seem to be safe, for example, in a fractious cat, one approach is to inject the animal intraperitoneally. This approach is frequently used in laboratory animals. Rodents are usually held by the scruff of the neck, as shown here. You can use pentobarbital, a drug that's slightly less caustic than the other barbiturates. When using this for cats, let them grab onto something with their forepaws while you extend the hind limbs off the side of the table or countertop and reach under to inject it. If the animal is slightly suspended so that its only sense of support is its forelimbs, it won't let go even if it feels the prick of the needle. But what if you inject intravenously, but it misses the vein? If it's a drug that causes sloughing, you should treat it by diluting the drug. Infiltrate the area with 1 or 2 mils of a dilute local anesthetic, and follow that with an anti-inflammatory compound and hot packs. The increased blood flow will help absorb the drug and lessen the inflammation. Even then, it may still take a few weeks to heal. After the intravenous injection of an injectable anesthetic, it distributes to tissues in a specific order. The first area where they accumulate from the circulation would be the areas of highest perfusion, such as the brain, spleen, and kidney. The ultra-short-acting drugs will increase in these areas faster than less lipid-soluble drugs. As a consequence, the more lipid-soluble drugs will induce a more rapid onset of anesthesia than the more polar compounds. This is the rationale for using them as induction agents clinically. Because of the time that's required to reach their peak anesthetic action, intermediate acting drugs like pentobarbital may produce a transient period of behavioral excitation rather than sedation. This is caused by inhibition of the dominant inhibitory tone in the brain, allowing excitatory centers to transiently dominate. After the majority of injectable anesthetics accumulate in the brain and other organs that are highly perfused, the drug then redistributes to organs that make up the greatest mass of the animal. In this case, in most animals, this is the skeletal tissue. But of course, because these drugs are highly lipid soluble, they're going to eventually dissolve in and stay longest in tissue with the highest lipid or fat, which of course is the adipose tissue. The consequence of this movement of drug during its redistribution is that it decreases the concentration of the drug in the brain sufficiently that it terminates the anesthetic effect. So even before the drug is either metabolized or excreted, there's not enough in the brain to be anesthetic. The other consequence of this redistribution is that if you want to prolong the anesthetic effect, a second injection produces a much longer anesthetic episode because the areas where it normally redistributes to are already saturated. So when redistribution is responsible for the termination of action of an induction agent, it usually can't be used to maintain the anesthesia. This is why many anesthetic combinations involve induction with one drug and maintenance with another drug. This describes the distribution and redistribution of an ultra-short-acting compound after an IV injection at time 0. The drug is taken up quickly by the brain, kidney, and spleen. Once the drug is maximally distributed to the brain, it continues to increase in the muscle and to a lesser extent and more slowly into fat. During this process, when the concentration peaks in the brain, this creates a new concentration gradient where the concentration in the brain is greater than in the blood. So instead of going into the brain, the drug actually comes out of the brain and back into the circulation, where it goes to the skeletal muscle and eventually into the fat. Although fat is not well perfused, it's an area where the drug is more soluble and tends to accumulate and may stay for a long time. So although the drug is still in the body in the same amount as when it was injected, the concentration in the brain isn't high enough to sustain an anesthetic episode. When the animal wakes up, as indicated at the red arrow, additional injections of the same drug produce a longer anesthetic effect because they have no place to redistribute to, because those tissues are already saturated with the drug. So the termination of anesthesia produced by a second and third injection is increasingly due to metabolism, which takes much longer. Here you can see that a long-acting barbiturate like phenobarbital will also distribute fastest to highly perfused organs, then to tissues with a large mass, and finally to tissues with the highest fat content. But because these longer-acting drugs are less lipid-soluble, the process is slower. Instead of minutes, it might take hours. During this time, metabolism and excretion have a chance to not only contribute to the termination of the drug's action, but play a major role in its termination. Metabolism of barbiturates is largely in the liver. Oxybarbiturates are metabolized by dealkylation in the liver P450 system, and thiobarbiturates are desulfurated in the liver and kidney and brain. But there's a high degree of variability in the rate of metabolism depending on the age, sex, and species. Cats tend to be slow metabolizers. It's slightly higher in dogs and horses, whereas sheep are fast and goats are the fastest. Because of this, goats are very difficult to anesthetize with barbiturates for long periods of time. In fact, the anesthetic episode of pentobarbital in goats is more like that of an ultra-short-acting barbiturate. This illustrates how a rapid metabolism can terminate the action of anesthetics if it's faster than that of redistribution. Barbiturates cause anesthesia in the brain and are metabolized in the liver, but long-term treatment with barbiturates causes changes in these two organs that influence their subsequent activity. First, drug disposition is the fate of drugs because of the action of the body on the drug. Barbiturates induce P450 enzymes in the liver, causing a change in drug disposition. The clinical consequence of this induction is to increase the metabolism of these and other drugs, so higher doses have to be administered to produce the same effect. Pharmacodynamic changes are changes in the action of the drug because of changes at the site of action in the brain. Barbiturates lead to tolerance and dependence so that more drug is needed to produce the same effect, that is tolerance, and the drug itself is needed for the brain to function normally. That would be dependence. But the ability of drugs to produce these changes is not identical. Long-acting barbiturates, the less soluble drugs, the less lipid-soluble drugs, induce enzymes in the liver better than short-acting, more lipid-soluble barbiturates. However, short-acting barbiturates produce greater changes in the brain than long-acting barbiturates. As a result, when we compare three specific barbiturates as examples of drugs with differing lipophilicity, we can see that phenobarbital has the highest ability to induce liver enzymes, but thiopental has the highest ability to produce tolerance and dependence. As a result of that, ultra-short-acting drugs also induce the most intense withdrawal, with the fastest onset of withdrawal symptoms. This corresponds to the abuse potential of these drugs. Ultra-short-acting compounds are the most widely abused of the barbiturates, causing an intense drug-seeking behavior in people. In animals, the significance of this is that hyperexcitability and seizures, two withdrawal signs, are more likely during recovery from an anesthetic episode during ultra-short-acting compounds usage than after long-acting, less lipid-soluble compounds. Now let's talk about some of the major cardiovascular effects of injectable anesthetics. Barbiturates decrease the stroke volume in the heart, and this decreases the cardiac output. The decrease in cardiac output, in turn, decreases blood pressure. There may also be arrhythmias. To address these changes, you may need to supply fluids or other measures to maintain blood pressure, and treatment with atropine-like compounds or acetylpromazine provides some protection against arrhythmias. Obviously, the goal of newer drugs is to avoid these cardiodepressant and arrhythmogenic effects. There is a strong depressant effect of most injectable anesthetics on respiration. So how does that happen? Respiration is normally controlled by three distinct drives. You can override the baseline rate of respiratory excursions using the neurogenic or conscious drive. For example, when you hold your breath or intentionally hyperventilate. But when animals are asleep, the neurogenic drive is not active. Then the chemical or chemogenic drive is a response to the rising levels of PCO2 and decrease in pH in the cerebrospinal fluid and arterial blood. This is what normally regulates respiratory excursions at rest. But in the event of an emergency, the body has the hypoxic drive as a backup. It's activated when the concentration of oxygen decreases below an acceptable level. At rest, the hypoxic drive is normally not as active as the chemogenic drive. This graph illustrates the effect of respiration on the concentration of PCO2 in the blood. With each respiratory excursion, the PCO2 increases at the end of the breath until it reaches a critical threshold sufficient to activate the nerves that initiate another breath. The PCO2 decreases in response to the breath and then gradually increases again until another breath is initiated, perpetuating the cycle. Breathing is activated by neuronal activity that builds up in the absence of a breath, gradually increasing the discharge of the nerves to a maximal activity about 30 seconds. You can actually experience this by simply holding your breath. You'll notice that the urge to breathe builds up to that time, and then, if you're in good shape, tends to decrease very gradually after that point. People who dive for a living learn to suppress this response, allowing them to hold their breath for several minutes. After the intravenous injection of most injectable anesthetics, the threshold for PCO2 that's required to initiate a new respiratory excursion is increased. This means that more PCO2 is needed to initiate not only the first breath after the injection, but for each one thereafter. You'll notice that because of the time that it takes for the new level of PCO2 to be reached immediately after the injection, there's a transient period of apnea or cessation of breathing until the new breathing pattern kicks in. Clinically, this should be monitored to be sure that the animal eventually responds to the PCO2, and artificial ventilation may be needed if the apnea persists. Here you can see the effect of normal respiratory excursions on the PO2 in the blood. With each breath, the concentration of oxygen increases and then decreases at the end of each breath. The normal threshold for activation of the hypoxic drive is usually lower than what's needed to maintain respiration, which is usually initiated by the chemogenic drive. You can experience the hypoxic drive if you're in really good physical condition, when you hold your breath for a minute or longer. After the 30-second peak in chemogenic activity, as we described in the previous slide, the urge to breathe gradually increases again, peaking at about 3 to 4 minutes, when the hypoxic drive activates the nerves going to the brain, forcing you to breathe, even if you're unconscious. After injection of a respiratory depressant, there may be sufficient inhibition of the chemogenic drive that the hypoxic drive becomes active and important. In this case, a new pattern of respiratory excursions will be triggered by decreasing concentrations of oxygen rather than by the increasing concentrations of PCO2. In the event that a large dose is given, instead of simply shifting the control of respiration from the chemogenic drive to the hypoxic drive, there may be a dose-related suppression of the hypoxic drive. If decreased sufficiently, the clinical consequence, of course, is death unless respiration is mechanically supported. This is the mechanism of action of these drugs when used for euthanasia. Pentobarbital, together with phenytoin or high concentrations of potassium, produce unconsciousness, respiratory arrest, and finally cardiac arrest. Barbiturates cause a wide spectrum of effects in the body that may differ from one drug to another and from one patient to another. This often includes things like enhanced secretion of fluids in the bronchiolar tree. In small animals, atropine-like substances like glycopyrrolate are given prior to surgeries to block this effect. There may be a decrease in intestinal motility that should be monitored post-surgically to ensure that the GI tone and propulsion is back to normal. After surgeries using barbiturates, there may be a period of hypermotility and spasms as the drug wears off. This is somewhat like a withdrawal symptom because the body has adapted to the presence of the drug inhibiting motility. You need to monitor this and treat accordingly for pain and spasms. These drugs inhibit uterine contractions, so they should not be used for parturition. And somewhat surprisingly, they also can cause a situation in which the larynx is more sensitive to touch. So in some animals, there may be laryngospasms during intubation, and you need to be prepared for that. So to summarize, the adverse effects of barbiturates include cardiovascular and respiratory depression, the possibility of regurgitation and ruminants, respiratory excitement during induction, especially if a sedative has not been administered, and fetal depression because the drugs do pass into the placenta. There's no analgesic effect of barbiturates, so additional analgesic drugs need to be administered to prevent sensitization of pain-sensing fibers during surgeries. And after surgery using barbiturates, there may be a slow recovery, especially in some breeds like greyhounds. This can manifest itself in things like crying, shivering, increased respiration, thrashing about, or even limb damage. Given these problems with barbiturates, it's not surprising that newer drugs are increasingly replacing the use of ultra-short-acting barbiturates for induction of anesthesia. The next segment focuses on other injectable anesthetics, detailing their advantages in clinical medicine as well as the adverse effects that they might still produce.